Hi, I'm here to discuss a trending topic that is mucormycosis. Now, media is calling it as everybody knows, black fungus, and everyone is sending messages and pictures of the this black fungus infection, but that is a misnomer actually. We'll see what exactly is mucormycosis. Mucormycosis, it's an opportunistic fulminating fungal infection, and that is caused by the group called Mucorales. There are rhizobus species of this group Mucorales, which is frequently causing the infection in an immunocompromised patient. Mucormycosis is most frequently affecting the sinus and the nasal cavity, which occurs in 39% of the population. Then there is pulmonary mucormycosis in 24% of the population. There are cutaneous, cerebral, gastrointestinal, disseminated. This disseminated accounts for 6%. Who are at a high risk of contracting this mucormycosis infection? Let's see. That it involves high risk candidate, that is poorly controlled diabetes mellitus patients, especially with ketoacidosis and juvenile diabetics, and organ transplant individuals. This organ transplant recipients will be taking high dose steroids to reduce the rejection. For them, they are even at risk of this mucormycosis infection, and who are at long-term corticosteroid therapy, then neutropenia in the setting of hematological malignancy, patients on chemotherapy who has burns and other immunocompromised states. Now, we'll see where and all it affects and what are the symptoms produced by this mucormycosis. It can cause headache, that is continuous severe, usually unilateral headache will be the present symptom. Actually, I have seen some 2-3 cases recently in my wards when they were complaining the same thing. One of the patient had unilateral headache, which later progressed to bilateral headache, and one patient had the swelling of the eye with lid edema. Then some people will cough up, telling this. The patient was complaining he had blackish discharge when he was coughing up, and some patient will have that fever even after giving broad spectrum antibiotics. They will still continue to have fever. Then retro or periorbital pain and periorbital swelling. Now these are two pictures of the one is a cutaneous mucormycosis in post-renal renal transplantation, and this is a turbinate, left to middle turbinate infected by the mucormycosis. Basically, it will cause that cavitation, invasion into the tissue. Now, usually how the mucor enters. The mucor enters through the nose by inhalation, and more rarely by digestion or percutaneous inoculation. Now, after entering to the nose, what happens? This will directly go to the nasal mucosa, and there it will get attached. There it starts forming spore formation. This mucormycosis, one of the most important peculiarity is it can cause angioinversion, and it can also cause thrombus and necrosis. So it will further causes arterial thrombosis and ischemic necrosis of the affected part. When it enters, it will enter into the maxillary sinus and sometimes into the ethmoid sinus, and through that it will next enter into the orbit, which causes the orbital involvement. It can even spread to the intracranial route through ophthalmic artery, a superior orbital fissure, or the cribriform plate of the ethmoid. Now, what are the clinical features? First of all, it is divided into 3 stages. The first stage is sinonasal disease. That time, that is the best time you can pick up the disease. That the patient will start complaining of headache, nasal discharge, facial pain, and swelling and fever. And there will be nasal crusting, necrosis of the turbinate, palatal necrosis, and perforation. The stage 2, which involves rhino-orbital disease, there will be loss of vision and diplopia. There will be conjunctival chemosis, proptosis, ptosis, and ophthalmoplegia. Then the third one is the orbitocerebral stage, which causes facial and other palsy, and there will be altered sensorium. It can lead to covers sinus thrombosis, altered mental function, and hemiplegia. Now, the most important thing is the correct evaluation of a muco patient. Detailed history of the symptom which started first is very important. And we should give an ENT, an ophthalmic, and general physician consultation to see in which route the disease is actually spreading. And the basic panel should be done, which involves SCBC, RFT, blood glucose, and the gases. This blood glucose monitoring is very important in the current scenario of COVID patients, because if we are giving steroids also, we should see whether the sugar is under control. And analysis of the urine for the kitten bodies is another important thing. Then this nasal endoscopy is one of the best tests to see whether there is any mucor, and you can take a biopsy. Histopathological examination, KOH preparation. Now we are doing KOH preparation of this mucor if they have discharges from the nose and all, and if there is any tissue, we can do KOH mount. In this KOH mount, there will be acetate hyphae, CT scan, CT of the PNS and brain to assess the extent of disease. Contrast enhanced CT, you can see the extent of disease. And CT also determines the lesion's extension towards the orbit and the brain. MRI is more effective in assessing the vascular and cerebral invasion. And it can also screen for the cerebral involvement before the onset of signs. Now, evaluation of the mucor patient. First, you have to do a nasal endoscopy with biopsy from the ethmoids. Then the CT of the paranasal sinus. That finding will be disproportionate to the clinical features. And fungal staining, 10% Kirchmann would give an early result. Fungal culture on seborrhous media and HPE can be done. The hallmark of the sign, or which you can see in mucormycosis, is the black necrosis of the turbinate. These are the black and left middle turbinate and black and right middle turbinate. This is too much extension. That is a palatal necrosis in a diabetic patient due to mucor. This is almost the third stage. If the patient has this palatal fistula or palatal necrosis, patient would easily have a brain involvement also. The left periorbital swelling in an uncontrolled diabetic patient since 40s. These are also the similar photos. Then left periorbital and facial swelling in a juvenile diabetic. Right side orbital cellulitis in case of leukemic patient, and this outcome is very bad. You can see the diseased tissues marked as star, that is prone to necrosis and devitalization, which in turn leads to lack of the enhancement seen in MRI. That is a black turbinate sign. Now, treatment modality. The first and most important line of treatment is amphotericin B. And an early FES is very important, so that if it's just confined to the maxilla, you can do a surgical debridement of the involved paranasal sinus, that is maxillary sinus, or if it's in ethmoid sinus. Continue with amphotericin B and repeat debridement if required. Most importantly, control of the underlying factors should be done. And this new antifungal called posaconazole, which is now available. Now, amphotericin dose you can just go through, but the main important thing is adverse effects of amphotericin. That is, there can be hypokalemia, so you have to monitor potassium values, and nephrotoxicity is another important problem. You have to keep an eye on serum creatinine and blood urea levels, and blood urea is more than 15 milligram per person and serum creatinine more than 5.5 means the dosage should be reduced or the drug should be stopped. There is another preparation called liposomal amphotericin, which won't cause any nephrotoxicity and it has very less adverse effect. It can be given in the dose of up to 2 to 3 milligram per kg per daily, but it's very costly. Now, take home message is prevention is always better than cure, and early detection of the mucormycosis and notification in the DHO is must. Alarming signs need to be assessed, and diagnosing nasal endoscopy help to find out the earliest disease. And surgery that reduces the load so that amphotericin will work properly. Sometimes signs and symptoms are disproportionate to the patient cause comorbidities and very physical findings that can happen, that had happened for many cases. Despite surgery, there may be a worsening of symptom as surgery reduces the load of disease, not the vascular inversion. I hope this has helped. Thank you. Thank you.